No.
All right,
Okay,
are
so
we
it's
live?
good. Let me make sure you are screen sharing. Okay, I think we're good. Thank you so much.
All right, well, good morning and thank you all for coming. When I got the list of all the cardiology topics that are on the CCRN, it is too hard to cover in one setting. So depending on how this goes, I'd be happy to do another lecture at some point in time. But today, we're kind of going to focus on, I actually did some practice CCRN questions. And I was kind of surprised at the level of ECG and things on there. So we're going to kind of start with EKG stuff and kind of go through acute coronary syndrome and sort of end in shock. Okay. Let's see here. Okay.
Does that work?
So all the cardiologists are always obsessed with what does the EKG look like. There's a lot of good reasons. So we're going to kind of start looking at EKG. So just some basics: rate, rhythm, axis, and intervals, and then we'll kind of talk about things throughout each. So we have to do a combination of things here. Okay, so EKG, you start with the P wave, and then you have the PR interval, then you have the QRS complex, and then the T wave at the end, okay? So this is helpful as we go through. So this is really what is happening in the atria or the top chambers. So when this is occurring, the atria, this is what is causing the electrical impulse for the atria to contract. Then electricity goes to the ventricles and the ventricles contract. And this is that whole segment. And then after you go back here, and this is where, so this is systole and then diastole, okay? And so when you look at rate, I don't think they would trick you on a test question or anything, but in some of the EKG questions, I did notice they do have, you always want to look for the sweep speed on an EKG. Almost all EKGs are 25 millimeters per second. And that only matters because of determining your rate and all the intervals, because that'll change. So pretty much normal is 25. So that means one small square is 0.04 seconds. And then one big box is, 5 small squares, one large square, 0.2 seconds. So when you're looking at an EKG, there's a lot of ways and tricks to calculate the rate. But anytime you're on a test and things, I find the easiest way is to know an EKG is a 10-second strip. So if you count the QRS complexes and multiply by 6, that'll give you a rough estimate of what the heart rate is. So normal is 60 to 100, less than 60 is defined as bradycardia, greater than 100 tachycardia. And so when you're looking at the QRS to determine the rhythm, you're always looking at the P wave. And then there are 2 leads that are the most important, which is lead 2 and V1. And so if it is normal sinus rhythm, the P wave will be upright and positive in lead 2, and it'll be biphasic, or it'll have at least some upward downward projection in V1. Sometimes in real life, when you're looking at EKGs, V1 can look mostly negative. That's okay as long as 2 is mostly positive. For the most part, if there's a P wave, 99% of the time, it is going to be sinus rhythm. But there are times where it's not sinus rhythm, and then we're going to kind of look at that. So here's an example. So you see in lead 2, the P wave is upright, and in V1, it doesn't have much of a downward deflection, but you just have to trust. That's why I say lead 2 is the most important. If you have a normal P wave and it's upright in lead 2, it's almost certainly sinus rhythm. But this is kind of a normal EKG right here. This you can see here. In lead 2, you have an almost completely downward P wave, right? And then in V1, you have this big upward hump P wave. And it just doesn't look right. Like when you look at it, it just doesn't look like a normal EKG. This is an example of an ectopic atrial arrhythmia. And so you can see these upright, and then, like I said, lead 2 is the easiest to see. And so big downward deflection there, ectopic atrial rhythm. And then other rhythms, so atrial fibrillation, you all are probably used to seeing irregularly irregular. If there's no P waves, then atrial fibrillation. Atrial flutter can be regular, but you see multiple what look like P waves or multiple flutter waves. It can be irregular if there's a variable block, so you'll have 2-to-1 block, 3-to-1 block, and so that'll make it irregular. I don't know if they would test this for you. They like to test this sometimes for us, but if you ever see a rhythm that is very irregular, irregularly irregular, but there are very clear P waves that are not flutter P waves, think about what's called wandering atrial pacemaker or multifocal atrial tachycardia. That often occurs in the ICU. You see it actually a lot in hypoxic patients. So patients that are really struggling, they're hypoxic. I've actually gotten multiple consults in COVID with that too. You'll look at the EKG and it looks really weird because you think it should be AFib, but there's very clear P wave. And when you look, the P wave morphology is different. And so usually to define it as multifocal atrial tachycardia or wandering atrial pacemaker, you have at least 3 different P wave morphologies. And so something to keep an eye out. And then ventricular tachycardia, ventricular fibrillation, we'll go through in a little bit as well. So then when you look at the intervals on EKG, so the PR interval is basically from when the atria starts contracting until the ventricular starts. So normal is 3 small boxes to 1 big box. So 120 to 200 milliseconds. If you have greater than 200 and it's consistent, that's a 1st degree AV block. Less than 120 is called pre-excitation, or it can even be indicative of a junctional rhythm. If you have a P wave that's right on top of the QRS complex, sometimes that can be junctional. QT interval is really what defines systole. So this is when the ventricles are contracting. So they like to test this on any kind of test. They'll show you what looks to be a normal EKG, and they may give you some history where the patient may have hypocalcemia or something, but always be on the lookout for QT prolongation. And so kind of the eyeball test is if the QT interval is less than half of the RR interval, then it's probably normal. But if you see between the 2 QRS complexes, if the QT appears to be more than half of that, that's kind of a easy rule of it, there may be QT prolongation. The QT interval will change depending on what the heart rate is. And so that's why there's the measure, which you probably have seen on an EKG, called QTC. The C part is just corrected. It means the QT interval is corrected for the heart rate. And so to do that, you just take the QT interval and divide by the square root of the RR interval. I don't think they'll ever make you calculate it, but just know that like in bradycardic heart rates, the QT interval gets longer, and in tachycardic heart rates, the QT interval gets shorter. And so the QTC is always correcting for the variability in heart rate. So QRS complexes, you can have left bundle branch blocks. So normal is less than 120. And then if you have a QRS that's greater than 120, then it's usually some type of bundle branch block. Left bundle branch, right bundle branch, or you may even see something that's called interventricular conduction delay. And then ST segments are what everybody gets really crazy about, and we'll actually go through some of this a little bit later too. But with ST segments, that is where everybody is looking for ischemia. And so you can get early repolarization. So they'll talk about J point ST elevation, which is really where it's very curved upright. That can occur in pericarditis. It can also occur normally in young people. ST depression is usually a marker of ischemia, ST elevation, infarction. Like I said, we'll go through. So I always like to kind of make things patient-centered. It helps me remember. So we're going to start with a patient. Her name is I'm a Heartbroken. She's a 68-year-old female. She has a history of hypertension, hyperlipidemia, and she came to the emergency department with chest pain. Her chest pain's been going on for about 45 minutes, and she describes it as an elephant sitting on her chest, which is very rare for females to actually have classic chest pain. Heart rate's 108, blood pressure 162/98, temperature's normal, oxygen saturations are 98% on room air. So what do you want to know next? Yeah, all cardiologists want to know what the EKG looks like. So this is her EKG. Anybody see anything wrong? What? Yeah. So this is a good classic example of an anterior STEMI. You have ST elevation in V1 to V4 and reciprocal changes. And so we'll kind of go through some STEMI criteria in a little bit, but that is a very classic STEMI. Now you could say, well, it's not quite tombstoning, but it looks pretty tombstoning to me. And the fact that there are reciprocal changes, 10 out of 10 times, this is probably a real STEMI. And so, so with acute coronary syndrome, you know, we'll talk about the three things that encompasses, but is usually a marker of plaque rupture or erosion with associated thrombus. Now, this is getting more and more complicated for us every day because of high sensitivity troponins. Even the last set of troponins we had was still fairly sensitive, and now we have even more high sensitivity troponins. So that will make this a little more difficult, but when somebody comes in with symptoms consistent with acute coronary syndrome, elevated troponins, it is usually a marker of unstable plaque. And if you talk to even STEMI patients at home, they often have been having some symptoms before their STEMI occurs. They have had a couple days of intermittent pain, kind of some unstable symptoms. They sort of blow it off, and then they come in with their STEMI. And so acute coronary syndrome really, in its true definition, is unstable plaque that is causing symptoms. We see a lot of people that have, you know, worsening, just stable angina. They have a lot of chest pain with exertion relieved with rest. That is a marker of blockages, but for the most part, they're stable blockages. That is kind of what you expect. So it's really when people start to have chest pain at rest, chest pain that's kind of stuttering on and off all day, those are where you start to get concerned. So the three acute coronary syndromes are unstable angina, acute non-ST elevation myocardial infarction or NSTEMI, and then acute ST elevation myocardial infarction. So the biggest difference, so for true, so STEMI is kind of easy, right? It's an EKG diagnosis. If somebody has classic ST elevation, reciprocal changes, that's a STEMI, you move on to that pathway. When they don't have ST elevation, but either they have chest pain and EKG changes, then you kind of have to differentiate between unstable angina and an NSTEMI. And really the biggest hallmark difference is positive biomarkers. So for unstable angina, you really need to have chest pain and some EKG change to truly be called unstable angina. For NSTEMI, you would have either chest pain or EKG changes and a positive troponin. So in STEMI, time is muscle. So that is why everybody goes to the cath lab. So when you're looking at criteria for a STEMI, you want to see greater than 1 millivolt or 1 millimeter on the side. It'll go by millivolts, but basically you want to see at least 1 millimeter of ST elevation in all leads except V2 and V3. And that's just because where V2 and V3 are located. If you think about where you put EKG leads, V2 and V3 are the closest to the heart and usually have the biggest QRS complex. And so they're the most prone to changes. And so that's why most everybody says you need 2 millimeters of ST elevation, V2 and V3, but 1 everywhere else. Left bundle branch block is always like the bane of our existence because you never know, is it new, is it old? In the right setting though, you know, if somebody comes in with symptoms of chest pain and they have a left bundle branch block, you do usually take that as a STEMI equivalent. If somebody comes in for weakness or something, they have a left bundle and you don't know how old, that's kind of where you have to sort of tease out what you clinically think. But for the most part, chest pain, a good story and a new left bundle branch block is very concerning for LAD infarction. And then you always need reciprocal changes to truly classify it as ST elevation myocardial infarction. So treatment of STEMI goes straight to the cath lab. Things have been changed a lot over the last several years because of primary PCI and STEMI. And we're going to talk about some of the complications of myocardial infarctions, but in the emergency department, every chest pain patient should get aspirin. Hopefully they get it en route via the ambulance. They usually get heparin. You know, if somebody has an NSTEMI, then you can treat with Lovenox and different anticoagulants. But for STEMI, because you think that you're going to take them straight to the cath lab, almost all of them get heparin. And then P2Y12 inhibitors, Plavix, ticagrelor, prasugrel. There's a bunch of different trials that have been done that have shown that ticagrelor especially and prasugrel both are more effective in STEMI. The only part about prasugrel or Effient is that trial, they were loaded in the cath lab, so they were not loaded in the emergency department. And then, so we have been trying to go out of favor. We're trying to protocolize it here. It's not as protocolized because every cardiologist does it a little different, but ideally they would get ticagrelor. And the right answer on a test is that they would get loaded in the emergency department before going to the cath lab. Oxygen, you know, there used to be this acronym for patients having a heart attack. You give them Mona-B, morphine, oxygen, nitrates, aspirin, and beta blockers. The oxygen part of things actually has gone out of favor unless they're truly hypoxic. It's really not been shown to help with much of anything. And then the other things you have to be careful of, and we're going to talk about some things with myocardial infarction that you have to watch out for, but nitrates, if their blood pressure is high and they can tolerate it, you can give them nitrates. That does help their chest pain usually. Morphine, you can give them too. And then fibrinolysis, so they may test you on this. So a patient that's at an outside hospital that's 2 hours away from a primary PCI center. So 120 minutes is kind of the golden rule. If they're greater than 120 minutes from a center that could do primary PCI, then they should get lytics. And so we actually see that here more than I've ever seen it because there's a lot of outlying feeder hospitals that give us patients. And if they cannot get that patient here within 2 hours, then they will get lytics there. We'll bring them to the emergency department here and reevaluate. Do they need to still go straight to the cath lab? Can you let them cool off for a little bit and then you'll always take them within 24 hours, but you'd like some time after giving lytics if you can. So here's an example. I wish this picture were the same angle, but it's not. But you can see up there, you see that cutoff? Everybody see that? So that is classic thrombotic occlusion. This is of the LAD. So here is where it's cut off, right there. And then here's where they put in the stem. So they've changed the angle, but this is where they've reopened the vessel. So that is what we do in the cath lab. So back to our patient, 4 hours later in the CCU, she rings the nurse call button. Nurse Minmi comes to the room and she reports that she's feeling very dizzy. He looks up at the monitor and sees that. So anybody have a thoughts as to what that is? You could think that. That's a good thought. I like that. So yes, reperfusion rhythm does happen often after STEMI, and you normally don't worry about it too much, but it's normally slow. So it looks like slow VT. It's a wide complex rhythm that usually is in the 70s to 100, but it's usually slow. And so that's what we call AIVR or reperfusion rhythm. But this heart rate's 177. Would you say that's wide or not wide? Yeah, looks a little wide. So I would call that ventricular tachycardia. So patients right after the first couple of days, right after MI, and even prior to MI, are very susceptible to ventricular arrhythmias. They get a lot of irritation. That's how we see a lot of out-of-hospital cardiac arrest, because people have a heart attack at home. And some people are unfortunate and they go into ventricular tachycardia early. So if this is your patient and she is awake and talking to you and dizzy, what would you do for her first? Yeah, it's good. Let's see where she is on the stability scale. And let's say her blood pressure is 130/70. What do we do now? Okay, phoning a friend is good. Phoning a friend is good, and that friend we'll get to in a minute. So we'll go through what we're going to do for Miss Heartbroken in her VT. First, we're going to talk a little bit about the complications of infarction. So actually, before I do this, I already showed you that one. What are some other complications of heart attacks that you all maybe have seen or heard of? Somebody can just start shouting out. Yeah, papillary muscle rupture. Yeah. Yep. So that kind of leads to heart failure. Some of that can lead to cardiogenic shock. What else? Huh? Yep. Stent thrombosis. Good. Any others? Yep. So that's the cardiogenic shock piece. So good. So heart failure, pulmonary edema, cardiogenic shock, which we talked about, complete heart block. So we'll go through this, but complete heart block, does anybody know what heart attacks you see them? Inferior, anterior, or lateral? Yeah, that's right. Inferior most commonly because the right coronary artery feeds the conduction system. And so that can lead to heart block. RV failure, so same thing in inferior infarcts. You can get what's called RV infarct, and they're very difficult to manage and associated with high mortality and morbidity. Free wall rupture too, so especially LAD infarctions. Some of these are late, and we'll talk about them. We don't see them as much because there's been such an awareness about heart attacks and getting to the cath lab early and getting the vessel opened up, that some of the free wall rupture, papillary muscle rupture, you don't see as much anymore because we're able to get reperfusion early enough. Pericarditis is another one. And then papillary muscle rupture. I did not put stent thrombosis, but that definitely can for sure be one. So ventricular arrhythmia. So this is a good EKG example of VTAC. It's a wide complex rhythm, it's very regular, and you don't really see any P waves. Sometimes you can look at the EKG and you can see P waves that don't correlate to the QRS complex. That's called AV dissociation. That's kind of a hallmark sign of ventricular tachycardia, but this is just run-of-the-mill ventricular tachycardia. This is what you call monomorphic, which means every QRS complex is about the same. This starts to get very scary looking. So you could call this a couple of different things. I still think early on, I would probably call it polymorphic ventricular tachycardia or torsades. You know, torsades, you'll see that's kind of the description of twisting of the points. You'll see kind of high amplitude and low amplitude. Torsades is very scary because it degenerates into ventricular fibrillation very fast because it's very unstable. You can actually see it in ischemia. So polymorphic VT is actually more common in acute ischemia than the left-sided monomorphic VT. So the left-sided VT is typically more related to scar. So when people have had heart attacks and later on they come in with ventricular tachycardia, that's usually that type of ventricular tachycardia because a scar has kind of basically kicked up a focus and it's made the heart irritable. And that focus is coming from the same spot. But in acute STEMI ventricular tachycardia, the heart is so irritable that it kind of comes from a lot of different points. And that's why it can look very polymorphic and why you see that in acute MI. And then this is ventricular fibrillation. So when you just have very erratic, you really can't march anything out, very difficult to predict what the next beat, this would be very fast. So one big box in between is about 300 beats a minute. So this is very disorganized and probably a little faster than 300 beats per minute. So the biggest thing when you see ventricular arrhythmias in the unit, especially in cardiac patients, you know, ACLS changed a little while ago, but the first thing to do, no matter what, I mean, you can do CPR while you get things set up, but early defibrillation matters most. Shock them again and keep shocking them because that is what I mean, you will have to do some CPR in between to circulate drugs if they do not come back, but you don't wait 2 minutes anymore. You know, used to when ACLS first started, you would do CPR for 2 minutes and then shock. But now we know, especially in a known cardiac patient, when they go into ventricular arrhythmias, the earlier shock, the better. So as soon as you get it hooked up, shock them. So patients, especially that are stable at first, will also often complain of palpitations, dizziness, lightheadedness. So step one, hook them up to the pads and kind of see, because you really don't want to shock a wide awake patient if you can help it. If they have a pulse and they have a stable blood pressure, you have a little bit of time, but you want to be ready to shock them in case they deteriorate. Step two, so if they're stable and awake, trying an antiarrhythmic, amiodarone and lidocaine are the most common. And if unstable, then you have to defibrillate. This came up a bunch when I was doing these practice questions. And so I don't know if this will come up on the test of any sort, but they did make a distinction between biphasic and monophasic defibrillators. So if you have a biphasic defibrillator, then that's usually you shock them at 200 joules. If you have a monophasic defibrillator, then 360 joules. So heart failure and cardiogenic shock. So those are probably some of the most common so ventricular arrhythmias is the most common complication of MI. Heart failure probably is too, but cardiogenic shock is not, but it is the most mortality. This is a famous table that one of actually my old mentors came up with. She's very brilliant, but basically when you go evaluate an MI and heart failure patient, you want to ask yourself a couple of questions. Are they warm, or are they wet? So this is like a 4x4 table if you can kind of follow. So on the top is basically, are they congested at rest? Like, do they have markers of volume overload, pulmonary congestion on chest x-ray? So if the answer is yes, then they are wet. If the answer is no, then they're dry. On the left, kind of y-axis side, low perfusion at rest. So that's evidence of low output. So some of you all said things about low output earlier. So decreased urine output, altered mental status, cold and clammy extremities. All of these things are signs of low output. And you can directly measure them if you have a swan. And so probably the most common place for people after MI to be is warm and wet. So a lot of them are not in cardiogenic shock, but they do have elevated filling pressures. In the cath lab, you'll see cath lab reports with LVEDPs. That's a measure, LVEDP and wedge should be the same as long as there's no mitral valve disease. And so when their pressures are elevated, you usually will have to diurese them, but most of them are warm. Rarely are they truly warm and dry. Maybe a CERC STEMI that came in early, got revascularized, did fine. Cold and wet is sort of classic cardiogenic shock. So if they're cold and wet, means they have too much volume, but at the same time, you probably can't just diurese them because they're too cold and they don't have enough perfusion. And so to get diuretics to work, you have to have blood flow to the kidneys. And so that's where you have to figure out a way to make them a little bit warmer. And then cold and dry is actually very rare, and it's a very difficult place to be. It's very hard to treat them. So this is just that table again. This is kind of looking at treatment of some of those things. So cold and wet is cardiogenic shock. And low output. So if their blood pressure is above 90, you'll see us use a lot of vasodilators. So nipride is a good vasodilator to use up front because it's short acting. So that's why we all go, some of us do nipride early, because before you start adding hydralazine or lisinopril and things, you want to see if they'll tolerate it. And so nipride is quick on and off. So you want to see if their blood pressure is greater than 90, if you have room for what's called afterload reduction. We'll talk about afterload in a little bit. But you want to see if you can create forward flow by decreasing their resistance, and so decreasing their blood pressure a little bit. And then you can give them inotropes and loop diuretics to see if you can diurese them. Warm and wet is really just about getting the volume off. So it's really just about diuresis heavy. In the bottom left, cold and dry, that is where you have to kind of give inotropes and fluid, but you have to kind of be gentle on fluid because it'll back up really easy. Those are the ones I told you that they're the hardest to deal with. And then warm and dry are pretty stable. They're the most stable group of this population. So really you just want to start them on heart failure therapy. You can be a little quicker to start heart failure therapy. One thing you have to be careful of, and you can see if you're the nurse in the unit for a STEMI patient, if you have a STEMI patient that has a heart rate of like 115 and a blood pressure that's hanging low, people will want to start beta blockers too quick because they're like, well, they're tachycardic. But that usually is a sign that they're sort of riding the cliff. And so you can really turn a patient like that into a cardiogenic shock patient with beta blockers. So you'll see that if you have a patient that just had a big STEMI and you start giving, somebody's ordered carvedilol for them and they get sick really fast, they're probably in cardiogenic shock. So complete heart block often occurs with right-sided STEMIs because of that's what feeds the conduction system. You can also get that with reperfusion too. So even once you start reperfusing the conduction system, they can still go into complete heart block. It's a very odd arrhythmia, but this normally always resolves in the setting of a heart attack. I mean, if they had a very late presentation, maybe it would not. Some of them will need temporary pacing, but rarely do you have to put in a permanent pacemaker. RV infarct, RV failure. These symptoms mostly are nausea, vomiting, diaphoresis. They're very hypotensive when they come to the emergency department. And you cannot give them nitrates. If you give them nitrates, it will bottom them out, because you'll see this in RV failure in general. So patients that have PE, patients that have, for whatever reason, their RV is failing, they are dependent upon volume. And so the treatment for RV infarction, RV failure in the setting of a heart attack is actually fluids. Usually this occurs because the right ventricle is fed by what are called RV marginal branches that come from the RCA. So if somebody comes in with an RV infarct, it is almost always a very proximal RCA occlusion. And so the treatment is to increase their preload, aka increase their volume. So you give them fluids gently. Free wall rupture is a disastrous complication. So this is what you call a late complication of MI. It occurs about 3 to 6 days after MI, and you'll have a patient that's kind of doing okay, and then boom, they just code. And it is rarely survivable because it's very hard to pick up that that's what happened. But basically just where the muscle is infarcted and then muscle around it is contracting, it can just create a rupture or a tear in the heart. And they develop a big pericardial effusion, blood accumulates in the sac around the heart. And like I said, it's very difficult to pick up. It has greater than a 90% mortality. They'll usually have, if they do have any symptoms first, some of them have chest pain, and then they'll develop very acute increased shortness of breath, increased JVD, and then usually they will arrest. This can be difficult to distinguish from papillary muscle rupture because they also do the same thing. It's very acute. They go from doing okay to not doing okay. And we'll talk about papillary muscle rupture. Pericarditis is also common. So you have 2 phases of pericarditis. The first they can have as soon as they come back. So there are patients that'll come up to the unit that had a STEMI, and then they'll pretty quickly develop sort of chest pain, but it's different. It's sharp to when they take a deep breath in. That's more pericarditis type pain. And you can see that in the early phases of MI too. They can also get an inflammatory pericarditis about 6 to 8 weeks after their heart attack. And that's called Dressler syndrome. So papillary muscle rupture is kind of like free wall rupture, about the same time frame, 3 to 5 days after MI. You'll get acute mitral regurgitation. So the mitral valve is held together by 2 papillary muscles, and then they have these cords that attach to the mitral valve. And so in some heart attacks, depending on the blood supply, you will have no blood flow to the papillary muscle. And so when it has no blood flow, it does kind of like the heart muscle can, and it'll just rupture. Increased shortness of breath, it's very acute because it's so much volume and the heart has not had time to accommodate all of that. You often may not hear a murmur. So that's what can be hard, is about 50% of patients have a murmur of mitral regurgitation. And then usually the treatment for this is balloon pump early. This is one of the areas that we still use balloon pump a lot. It does seem to help significantly. You try to stabilize them and then get them to surgery as soon as possible. So this is the mitral valve. So you have a posterior medial papillary muscle and an anterolateral papillary muscle. And you can kind of see there's the papillary muscle at the bottom, and then the cords that attach to the papillary muscle. Usually you have papillary muscle rupture because of blood supply issues. So most common papillary muscle to rupture is the posterior medial because it only has one blood supply. It either is supplied by the circumflex or it's supplied by the RCA. The anterolateral has 2 sources of blood supply, and so usually that does fine. Okay, so back to Miss Heartbroken. So we have this on telemetry, and she's stable. Her blood pressure is 130. So what we have to do now is kind of go back to ACLS training. So stable ventricular tachycardia patients with a pulse, you try not to shock them until they become unstable because they're wide awake. And so you would use amiodarone or lidocaine. And so I saw that question kind of come up a couple of times, but this is just the algorithm that you can look at for tachycardia with a pulse. But basically it's about continuing to assess them. And the moral of the story is if they're awake, try antiarrhythmics first. if a cardiologist is nearby, they may try to pace them out and things, but you try conservative things. When patients start to become more and more unstable, then you have to do something about it. So if they start to develop hypotension, but they're still awake, this is the time where you have to do what's called synchronized cardioversion, which basically means, you may have all done this, you hit the sync button on the code cart, because when you do that, that syncs it up with the QRS complex, and it helps the timing of delivering of the shock. And you do want that. That's important, because if you are not careful with that, then you can end up in ventricular fibrillation. And so, and then if they become unconscious, that's when you go straight to defibrillation with either the 200 joules biphasic or 360 joules monophasic. All right, so after ROSC, her blood pressure is 72/54, heart rate 125. She's now intubated from the code, following commands, increased JVD, cool, clammy extremities. Who thinks she has cardiogenic shock? Agree. So she has now gone from sort of that warm and wet to cold and wet. And so just kind of going through some hemodynamics. So stroke volume is something that we talk about from a hemodynamic standpoint. Basically, when you talk about stroke volume, cardiac output, in stroke volume, we're talking about how much blood is ejected from the heart with every contraction. Preload, so that is the blood that is coming to the heart and that's in the heart. So really that is a volume issue, and we're going to look at the Frank Starling curve in a minute, but things that alter preload are volume. So you will drop somebody's preload if you remove volume, so diuresis, dialysis, CRRT. You will also drop their preload if you drop what's coming back to the heart. So that's where nitrates sometimes are helpful, and you'll see people put people on nitro drip. That causes dilation of the veins. So you get less, when you have dilation of the venous system, you have less blood flow back to the heart, and so you decrease preload that way. And then to increase preload, then usually you give them volume. And blood is actually the best volume expander of anything that we give. Afterload, you're really talking about the resistance in the aorta. What is the resistance that the heart is pumping against? So you can kind of think of that some in the way of blood pressure. It's not truly blood pressure, it's really more of the resistance. But we'll look at things with patients that have impellas or swans and things, heart failure. You'll be thinking about what is their systemic vascular resistance, because if their resistance is high, then you can use vasodilators, ACE inhibitors, hydralazine, nipride, all kinds of things to try to reduce their afterload, to try to help flow out of the heart. And then contractility is the force, how much muscle contraction is happening in a beat. So this is that Frank Starling curve. So on the x-axis, you basically see preload. So as you go to the right, that means you have more and more end-diastolic pressure, more and more preload. And on the y-axis is stroke volume, which is a measure of cardiac performance. So you can see, like, when you're dehydrated or dry, meaning your preload is kind of on the left side of the screen, then you will have issues with increased stroke volume. And there's kind of the sweet spot, like as the curve is at the peak, that's really the sweet spot of having enough preload to stretch all of the muscle fibers at the perfect line for them to contract the strongest. And then if you get volume overloaded, as in your preload goes up and your end diastolic pressure goes up, the right side of the curve, you can see how people kind of fall off the curve. And some people will refer to that as that. They'll say, oh, this patient fell off of the curve. This is the curve that they're talking about. And so you have to find that balance for a patient of what amount of volume and preload is enough. So we talked about this, the LV EDV or LV end diastolic volume and end diastolic pressure. is a measure of left atrial pressure, pulmonary wedge pressure, and PA diastolic pressure. If all the things in the system, there's nothing extraneous, there's no mitral valve disease, there's not a lot of lung disease, then all of those are pretty much surrogate markers for each other. You don't really keep anything in the ventricle. And so pulmonary capillary wedge pressure and PA diastolic pressure are kind of the easiest surrogate markers for what's actually happening in the ventricle. We talked about that. So you can decrease preload with diuresis and vasodilators. So things that can be done too in the ICU to help. So body position is a big one. So when they're lying flat, their preload is pretty much about the same and pretty much up. If they're fighting against gravity, then things are going to pull. So that's why patients get a lot of edema in their legs too, is because they have a lot of pulling of blood in their feet. And so you can increase their preload back to the heart, basically increase venous return by lifting their legs up. Increased intrathoracic pressure will also decrease preload. So that is why some patients, when you intubate them, may not do as well, because you're automatically giving them PEEP. And so you're putting a lot of pressure and giving them increased intrathoracic pressure. And so you can decrease preload to the heart. You decrease venous return back because of that pressure. You also increase pericardial pressure, same reason. Increased pericardial pressure does the same thing that increased intrathoracic pressure does. It creates a mechanism that the heart is fighting against. And so you'll decrease blood flow back if you have a big pericardial effusion and your pressures in the sac are high. And then if people go into atrial fibrillation, you'll see that too. Some patients are stable until they go into AFib, and then party's over. And that's because atrial kick, or the atrial contraction, is still about 20% of cardiac output. And so if somebody is riding on the line of stability and they lose that atrial kick, that may be enough to send them into cardiogenic shock. Afterload is what we talked about, kind of the resistance in the vessels. If you have really high afterload, the heart is trying to contract against basically that, kind of like blowing through a straw. It's trying to pump against all that resistance. So until you decrease some of that resistance, it may not get better. That's why sometimes you'll see us, even in weak hearts where patients have low blood pressure, you tolerate lower blood pressures because you want to decrease their norepinephrine, their vasopressin, their afterload constrictors, because that in turn increases the work of the heart. So you can lower afterload by vasodilators, nipride, nitroprusside, nitroglycerin, hydralazine. The two inotropes that will lower afterload are dobutamine and milrinone. That's why they can cause hypotension. Milrinone in particular, because it's a much slower excreted. It's also renally excreted. And a lot of our patients have renal failure. And so you'll see patients doing okay on milrinone until they don't. And that's usually because that's when they finally have caught up to steady state and their kidneys aren't working, they're having a hard time getting rid of the drug, and now they have a lot of drug in their system. And so milrinone, that's the one downside with milrinone, is it's kind of a longer on, longer off than dobutamine. You can increase afterload with, like, phenylephrine is a straight afterload increase. It does nothing else. It has no inotropic effect, no anything. And so usually you really try to avoid phenylephrine and neo and things like that in heart failure patients, because it just straight increases afterload. And so unless the patient is really limping along and you need to give them a push of something briefly, they usually won't do well with that. So we usually try to go with norepinephrine or epinephrine, vasopressin if they need something. And then contractility, the only thing you can do to increase contractility are the inotropic agents, dopamine, dobutamine, digoxin. And then we talked about this a little bit, but calcium channel blockers are a big no-no. We see that all the time. It's my pet peeve. Coming from the ER, a patient comes into the emergency department with AFib RVR, and if you talk to them, they have signs of heart failure, their volume overload, their chest x-ray has a lot of fluid on board, and then they start them on cardizem. And then after they start getting cardizem, they do really bad sometimes. That is because cardizem is a very strong negative inotropic agent. So if a patient is already kind of teetering the line of heart failure and cardiogenic shock, you can push them into cardiogenic shock with cardizem. Same thing with beta blockers. Cardizem is just a little bit more, but beta blockers too, that's why we talked about in STEMI patients, you know, you really always want to optimize their medical regimen, but the timing of that is important because if they're really teetering on the heart failure cardiogenic shock line, a beta blocker will also push them into cardiogenic shock. So you all are used to Swan-Ganz catheters. That's the best way to do hemodynamic monitoring. When looking at a Swan, you're looking at a lot of things. So the CVP. So CVP is a measure of preload, right? So that'll kind of tell you how much gas is in the tank. You can look at the PA pressure. That's also sort of a measure of preload. You're looking at the wedge, the PA diastolic. That'll tell you how much fluid is in the tank. And then you're really looking at afterload. You can calculate their systemic vascular resistance based off the Swan numbers that you get. You can also have a measure of their contractility with their cardiac output. You know, we use the continuous thermodilution Swans. You can check PA sats and calculate fit cardiac output. And so that is really that you'll see if you have some mind Impella patients and things, it is like flying blind without a Swan. I mean, yes, you can say, oh, their lactic acid's okay and this, that, and the other, but you really do not know what is happening with their heart unless you are monitoring these parameters because they do change. And as you're weaning people from pumps and things like that, it's so important to know what's happening to the hemodynamics. Okay, so Miss Ima heartbroken, comes to the CCU, she has anterior MI, oxygen saturation is 94. Her blood pressure is 92/68, heart rate 115, respiratory rate 26, CVP is 20, PA pressure is 34/8, cardiac index 1.8, mixed venous is 52. So where do we think she falls in our cold and wet, warm and wet, cold and dry, warm and dry? How about the wet part? Do you think she's wet? Yeah, right. Her CVP is 20. So definitely she's wet. Now, how about cold? Yeah, she has a cardiac index of 1.8. Normal is about 2.5. A mixed venous saturation of 52. They didn't tell us exactly what her hemoglobin is, but that's probably on the low side. So she's not super unstable cardiogenic shock. Her blood pressure, she still has a decent pulse pressure, but she's heading in the wrong direction, right? So what things could we do for her? Well, we should diurese her and see if she diureses. Sometimes, you know, if we go back to the Starling curve, see where that is. We go back to the Starling curve, you know, if she's on the right side of the Starling curve, she just has too much volume and she's gotten a little cold. If we diurese her and move her back to the left, we move her preload down, she may do just fine with that. And so you'll try diuretics first and see if she responds. And then if not, you can go to the inotropes and to the pressors. For her, you could probably try just a straight inotrope. That's where you will see in your career too evolve, and that is where things are evolving. But heart attack patients actually really don't like pressors at all. Their heart has just been under a lot of stress, and vasopressors increase what's called myocardial oxygen demand. It works the heart. Like, you know, you basically just took a heart that ran a marathon and crashed at the end of it, and then you're like, get up and run some more, because the vasopressors just kick the heart. It's just trying to stimulate it. So it's really increasing the need for oxygen. And usually in a heart attack patient, you really want to rest their heart as much as possible. They've just worked out really hard. You really don't want to work them out anymore. And that is where the use of Impella has kind of revolutionized acute heart attack care. Balloon pumps used to. Balloon pumps are not as good. They've never really been shown to change the mortality in heart attack patients and things, but Impella basically truly unloads and rests the ventricle. It's the one thing that the heart really needs at that time. It sucks blood out of the ventricle and dumps it into the aorta, and it really helps the heart rest, and it gives the heart time to heal. And that's the benefit of an Impella in these situations. So really in acute heart attack situations, we try not to use pressors at all. And if they're heading towards needing pressors, then usually you would have an early potential to put in an Impella. Sometimes you can get people with a balloon pump. You know, balloon pumps, they inflate in diastole, so that's when the coronaries fill. And so they inflate and then they suck in and deflate in systole. And that sucking motion of the balloon collapsing kind of helps pull blood out of the ventricle. It kind of creates that vacuum effect and pulls a little. It'll never do as much as an Impella, but sometimes if you just need a little bit, it can help. I mean, I probably use them the least of probably anybody, but I've put in one or two since I've been here. I don't know that I think they will completely go away. I still think their best benefit too is in like papillary muscle rupture. One other complication we didn't talk about as much is ventricular septal rupture, so you can get VSDs. I think balloon pumps have a good utility in those situations. I think for cardiogenic shock though, just AMI shock, for the most part, unless you cannot put an Impella in, Impella would be, and I think will in the guidelines eventually change to that too. So we talked about that, it increases. So the balloon pump indications. Balloon pumps also, the other thing, because they do increase coronary perfusion pressure, if you do have somebody that has refractory chest pain, you can use a balloon pump for that too. It sometimes does help. And then the Impella. So the Impella, like I said, is kind of a pigtail device. It sends into the ventricle. You see at the bottom, there's an inlet and an outlet. So basically it sucks blood in through the pigtail and dumps it into the aorta, and it helps kind of bypass the heart as it's weak. And that's why, you know, when you put an Impella in, you start unloading, you always have to look at the right side of the heart. The most common cause of right-sided heart failure is left-sided heart failure. But sometimes left-sided heart failure will mask right-sided heart failure. So I'm always very obsessed with knowing what the CVP is after I put a pump in. Because if you're unloading the left side, so now we have a CP in and we're getting 3 liters of cardiac output that's now dumped into the venous side and going back to the heart. Well, if the CVP starts climbing, that tells you that the right heart is not able to keep up with what you're putting back into it. So you either have to decide to support the right heart, or you have to kind of come down on your left-sided support and let the right heart catch up. And so that's why, to me, it is imperative to have monitoring when you have an Impella or a device like an Impella in, so that you know what's happening at all times. Are we going in the right direction? Are we not going in the right direction? And same thing, sometimes you can unload the heart so much, the CVP drops to 2, and then you can get suction on the Impella, and then you can get hemolysis and things. So you don't want that either. So you always want to know where you are. What is your preload? Is there enough fluid in the tank? Is there too much fluid in the tank? And then what can we do to optimize getting blood flow out of the heart? And with that, I think we will probably wrap it up. Oops, I did that. I stopped sharing. What questions do y'all have?
So no, this is a CCR interview, but like on the subject of having imperative need for a swan. In those cases where we have MLOs that don't have swan,
Yeah.
how, from a provider standpoint, how do we need to approach that?
I
as a
know.
nursing staff? Like,
It's the $1 million question. I think just asking, and not a like a I want a swan right now sort of way,
yeah,
but
like,
if just saying, yeah,
honey,
yeah. I think just asking like yeah, it is really frustrating. So if I take them over, I will always put one in. It really bothers me. But there are some that don't, and that's the old school flying blind thing. But you're just sort of like, man, we've done so much work. Let's not fly blind. I think just asking about it, and sometimes even asking more than once, like, and you can even say, like, if you have to call something, they're having suction or something's changed. Like you could even say, I really feel like having a swan could be helpful to know. And if they still say no, then they say no. I mean, ultimately it's them, and you've tried to advocate for the patient, but yeah, it's not perfect. I wish I could mandate it, to be honest. Yeah. Yeah.
Questions, anybody? Okay,
All
thank you
right.
so much. We appreciate.
You're welcome.
And we'll have you back anytime you want to come speak.